Good evening to all the aspirants. We are starting with the session. The topic for today is hematological management. And the speaker that we have here is Dr. Shraddha Patharkar, ma'am. She is Associate Consultant at ABMH Hospital, Pune. Thank you, ma'am.
Yeah. So the questions will be same as in the last class, but we have not covered 2 to 3 topics. So I'll be just going through those topics only. So which of the following statements regarding NOACs is true? So NOACs taken 48 hours prior in normal kidney function patients is not a contraindication for a thrombolysis in acute ischemic stroke patients. Means if the patient has taken NOACs, the time has lapsed beyond 48 hours, you can lyse such patients. NOACs are contraindicated in ACS patients as the secondary prevention for thromboembolic events without atrial fibrillation. NOACs are preferred over warfarin in thrombophilia and antiphospholipid antibody syndrome patients. All NOACs need bridging with low molecular weight heparin in treatment of DVT or pulmonary embolism. And only dialysable NOAC is rivaroxaban. So, which of the following is true? Can anybody tell me the answer? The questions that we have already gone through these questions in the last class.
Number one, NOACs.
Yes, yes. So, which one is the dialysable NOAC?
I think it is dabigatran.
Yes, dabigatran is dialysable. Uh, and the maximum 80% excretion of dabigatran is through renal route. So when your creatinine clearance is less than 30, you should not use dabigatran. While you can use rivaroxaban, apixaban between 15 to 30 ml per minute, but at a reduced dose. So we'll be seeing this in subsequent slides. So all NOACs need bridging with LMWH. So this is also false. So which NOAC needs bridging? Means first initial 48 hours you start with LMWH and then switch to NOAC.
It's dabigatran again.
Yes, yes. So NOACs are preferred over warfarin in thrombophilia, even that is false. So there are few indications, either because NOACs are not used in RCTs, in those RCTs, as that's why we don't have a sufficient data, and that's why in situations like thrombophilia and APLA, vitamin K antagonist, oral vitamin K antagonist like warfarin is preferred. Similarly, in pregnant patients with DVT-PE, warfarin is preferred over NOACs because we don't have a sufficient data to see the safety as well as efficacy. Um, Again, in LV clot, we can use, if because of acute MI, if a patient has developed LV clot, which is more common with a transmural MI. Again, NOACs, they are used off-label, but we don't have RCTs to support the evidence yet. So many of us we still use warfarin. And yes, both in atrial fibrillation as well as in without atrial fibrillation patients as a secondary prevention for thromboembolic events, NOACs we can use in ACS patients. That also we'll see in subsequent slides. So we should know these are the like dabigatran, apixaban, and rivaroxaban. You need to know everything about these 3 drugs because we are using these drugs day in and day out. So dabigatran is a pro-drug, and that's why for its peak action to come, it takes some time. But by and large, most of these NOACs, their peak action comes in 3 to 4 hours. So many a times you don't need crossover, like warfarin takes time to like after 2 to 3 days you'll get the therapeutic level of that drug in the blood. But for most of the NOACs, the peak action occurs in 3 to 4 hours. Bioavailability, again, the rivaroxaban has 100% bioavailability with the food, so it's recommended to take this tablet with food. And you need to know, see the like dabigatran has a least protein plasma protein binding, it is 35%, that's why it is dialysable. And rivaroxaban and apixaban, they have the maximum protein binding, so that's why they are non-dialysable. Again, time to peak I've already mentioned. So quicker action with these drugs. They are more potent also. And elimination half-life. So by and large, they are around 10 to 12 hours. And we know that in 3 to 4 half-lives, drugs gets cleared from the body. And that's why when the kidney function is okay, after 5 half-lives means maybe after 48 hours, ideally when the kidney function is normal, drugs should be out of the body. So we don't monitor these drugs level. I mean, whether they are therapeutic or supratherapeutic by measuring PT and APTT. But definitely, this dabigatran being direct thrombin inhibitor, thrombin time will be majorly increased. So if your thrombin time is normal, it means your drug is subtherapeutic. So you need, or maybe patient has skipped the dose and he has not taken, he has missed the dose. While APTT again, it will be much more increase as compared to PT in that being a direct thrombin inhibitor. While factor 10A inhibitors, you can expect PT to go up, especially with rivaroxaban at therapeutic levels also. And in apixaban, PT might be high when peak action of the drug occurs, mostly after 3 to 4 hours of intake. So that's why these are not reliable. But when patients are on these agents, PT, APTT might be raised. So again, regarding this bridging therapy, you can see that dabigatran, you need to bridge this with for dabigatran particularly. We don't use endoxaban. We don't have it. So dabigatran, you bridge in for almost 4 to 5 days, and then you switch to you start with LMWH for 4 to 5 days in DVT and PE treatment, and then you switch to 150 BD dose. For rest of the rivaroxaban, apixaban, there is no need to bridge in. For warfarin, again, you need that therapeutic INR to be 2 to 3, and for that, for first 3 to 4 days, you need to overlap that with LMWH. So here it is not bridging, it is overlapping. We are overlapping warfarin with LMWH. For dabigatran, we are bridging, and for apixaban, rivaroxaban, there is no need to bridge. Again, depending upon whether it is provoked and unprovoked, duration will depend on that. 3 to 6 months for provoked, and unprovoked you need to give lifelong. So again, you need to know the how to switch from NOACs to warfarin, from unfractionated heparin to NOACs. So I will not go into details of all these things, but just remember the onset of action of NOACs is quicker. So and we know that warfarin takes time for when we stop warfarin, it takes some time for his action to wean off and your INR to drop to less than 2. So whenever you are measuring INR, if it's a BD dose drug like rivaroxaban or apixaban, you have to measure INR just before the next scheduled dose, because by that time it's not completely drug will not get completely eliminated from the body, but your effect on INR will be lesser. So in OD dose, after next scheduled dose, after 24 hours, you'll be checking INR. And similarly, unfractionated heparin, we know that half-life is 90 minutes. So in 4 to 5 half-lives, action will wear off. So again, you are starting NOACs 2 to 4 hours after stopping unfractionated heparin. So you need to know the onset of unfractionated heparin. It takes some 90 minutes to 1 hour for the action, and elimination takes the 5 half-lives, so 6 hours around. NOACs takes 2 to 4 hours to peak. So these are the certain things, like even warfarin, you have to do INR, check INR every 1 to 3 days. And once your INR goes below 2, then you can start NOACs. If your INR is beyond 2, you cannot start NOAC. So again, these are like all theoretical points, but you need to know, because we are coming across such situations practically also. So again, depending upon creatinine clearance, dabigatran is contraindicated below 30 ml per minute of creat clearance, while rivaroxaban, apixaban you can still give in a reduced dose. So apixaban you should go for 2.5 mg/d. Dabigatran, rivaroxaban you can give 15 mg/d. Then again, dabigatran 90 to 50, it's better to give 150 bd. But below 50, dabigatran dose should be reduced to 110 bd. So it's always better in CKD patients and in patients with increased creatinine or reduced creat clearance. Choose rivaroxaban, apixaban over dabigatran. Again, in liver disease patients, when there is a child pox C class, you should not use any of these NOACs. In class C, no, none of the NOACs are recommended. But in class A, you can use dabigatran only in class A. Again, for liver patients, here you can use dabigatran, apixaban, but with caution. In class B, rivaroxaban should not be recommended. So again, in liver patients, rivaroxaban should not be used. Rather, you choose apixaban. So more or less, apixaban is safer, both in liver and kidney dysfunction. So when patient is on NOACs and if patient bleeds, how to go about it? You need to know this also, because if it's a mild bleeding, we know that in 4 to 5 half lives the drug's action will be cleared out of the body. So you might need to, if it's a BD dose, you need to skip one dose and see whether bleeding stops. Otherwise, and you have to reinitiate in absence of absolute contraindications. Like if there is a GI malignancy, upper GI bleed, then you have to wait a little longer. Otherwise, it's a minor bleed, you can just keep one dose and uh, see whether patient's bleed has stopped, and you can restart if it's not a if it's a mild bleeding. And if it's a major but non life threatening bleeding, where you can do mechanical compression, endoscopic hemostasis, in all these cases you have to consider the adjunctive measures. Maybe if the platelets are low, you have to replace that. If clotting factor deficiency, you have to correct it. Surgical hemostasis. And if you have used dabigatran, you can use idarucizumab or hemodialysis to reverse its action. So whenever there is a major bleeding, and if there is this is the advantage that we have antidotes available, so we can reverse it. And when it is a major bleeding which is life threatening or in some critical areas like closed space in ocular surgery, spine surgery, brain, so you have to use you can use idarucizumab 5 gram IV, factor 10 inhibitors depending upon how much time has lapsed, whether to give from the drug intake, whether it is 8 hours or beyond 8 hours. The dosage is different for andexanet alpha. Otherwise, if nothing is available, you can use 4-factor PCC, the dose being 50 units per kg. You can repeat it, maximum of 200 units per kg per day you can use that drug. So you just need to know the reversal agents and the dosages. So again, I have already described about idarucizumab. It is the antidote for dabigatran. Total dose of 5 gram. You can give 2.5 gram twice over 5 to 10 minutes, either infusion or bolus. And andexanet alpha, again depending upon whether 8 hours or more than 8 hours since the last dose that has been taken. So high dose and low dose. Again, you need to know for if there is acute emergency procedure, again the reversal is needed, and repeat coagulation panel you need to send, and targeted hemostatic intervention based on coagulation panel. So you have to, if the surgery is not that urgent and patient is on NOACs, it's better to defer surgery for 12 to 24 hours and then repeat coagulation profile, see whether there is a residual effect still there. So in terms of factor 10A inhibitors, anti-10A levels will be better to check. And for direct thrombin inhibitors, direct thrombin time will be better. But anyways, you have to send the whole coagulogram. So again, for low risk surgery and high risk surgery. Low risk surgery means where there is just the endoscopy without biopsy, or cataract surgeries, or dental extractions. So all those surgeries, or non-complicated PCI. In all these surgeries, you have to remember this chart: apixaban and rivaroxaban for up to creatinine clearance of 30 ml per minute. In low risk surgery, you can skip the dose for 24 hours, stop the drug for 24 hours, and there is no need of perioperative bridging with LMWH and unfractionated, because the levels will be very subtherapeutic, very low in 24 hours. And in high risk surgery, it's better to stop it for 48 hours till the creatinine clearance is 15 ml per minute. So again, dabigatran below 30 ml per minute, you should not use it. That should not be the choice. It's not indicated. So for dabigatran, again, you need to know this table. Like, if the creatinine clearance is normal for all NOACs, low risk surgery, 24 hours of stopping the drug is sufficient. For high risk surgery, 48 hours of stopping the drug is sufficient if the creat clearance is normal. If not, for dabigatran, you need to wait even till 4 days, if especially when it is below 50 ml per minute and high risk surgery is there. And if it is low risk surgery, then you have to wait for 2 days. So 2 days for low risk and 4 days for high risk, especially when 50 ml per minute and less is the creat clearance. And again, you can resume full dose of NOAC if it's a low risk after 24 hours, and if it's a high risk after 48 to 72 hours, you can resume the dose. Again, we have already discussed about this. So NOAC plasma levels, the first answer, which was the right one. So whenever acute ischemic stroke patient comes in and he fits into the criteria for thrombolysis, you can go for thrombolysis even before the coagulogram comes in, when you know that patient has taken his last NOAC 48 hours before, and his kidney functions are normal. When these two things you know about, you can go for thrombolysis. Otherwise, you have to send the coagulogram. Then if it's within 48 hours, then you cannot do thrombolysis. It's a contraindication for thrombolysis. Then you have to go for other means like endovascular thrombectomy. Again, when you lyse such patients, and if there is no hemorrhagic transformation, and if the reason for his ischemic stroke is embolic, cardioembolic or arterioembolic, and if you did anticoagulation, if it's a TIA, you can start NOAC even within a day, but without any focal neurodeficit and without any lesion on the imaging. When it is TIA with some lesion on the imaging, but there is no clinical worsening, you can start it within 3 days. So generally we call it as a rule of 1, 3, 6, 12. So 12 days means around 2 weeks. When you feel that patient had focal neurodeficit, but it is not worsening, on scan also, if before starting NOACs, 1 day prior starting NOACs, you have to get scan done. And if there is no increase in there is no bleed also, and there is no increase in infarct size, you can start NOACs in a severe neurological deficit patients in 2 weeks. Otherwise, you can start between 3 to 8 days. So you can start NOACs in cardioembolic ischemic stroke patients after looking at the scan, especially when there is a moderate to severe neurodeficit, between 3 to 14 days. And if it's a TIA, within a day you can start. And if it's a mild neurological deficit and there is a clinical improvement, within 3 days also you can start. When there is a hemorrhagic transformation, and but there is a clinical improvement and no worsening, Then you have to again document with CT or MRI 1 day prior to restarting NOACs. But here you have to start it beyond 3 days, up to 28 days. Again, the RCTs are not sufficient, so these are like on expert opinions. So there is a range of 3 to 28 days. So again, elective PCI, in emergency PCI, when there is an emergency PCI, you don't wait. Even when the patient is on NOAC, you go for PCI. Just during PCI, generally when patient is on NOACs, Bivalirudin or GP2B3A inhibitors are generally they don't prefer it. So you have to go through this table. Again, for warfarin, more than 5 INR, you have to hold until the INR is 2 to 3, and then restart dose, decreasing 15% every week. When it is your therapeutic range is 2 to 3. So if it is lesser, you have to increase every week by 15% and 10% according to INR. So you need to know this table as well. So beyond 5, you have to hold. 4 to 5, you have to hold just one dose and then restart with the reduced 10 dose. But beyond 5, you have to hold till the INR is in the therapeutic range. So again, with thrombocytopenia, you have to avoid NOACs when your platelet count is less than 20,000, because there is a risk of spontaneous bleeding. And between 20 to 50, you can consider half dose, but again, these are not not sufficient RCTs. But with caution, you can start NOACs between 20 to 50. Beyond 50,000, with close clinical and platelet monitoring, you can start. So the next topic will be APLA, antiphospholipid antibody syndrome. So regarding catastrophic APLA, all are true except it involves both small and large blood vessels. Autoimmune lupus-related catastrophic APLA has highest mortality. Infections, trauma, surgery, malignancy are the common precipitators. Raised APTT is the contraindications for using heparin. And anticoagulation, steroid, plasmapheresis, IVIG is the line of treatment. So all are true except which one is the false? Which one of these is a false statement?
Yeah, I can't hear.
Can anybody answer which one is the wrong statement amongst these? So catastrophic APLA involves both large and small vessels. It is true. And lupus related generally catastrophic APLA itself is has a high mortality risk. It is almost 40%. And in autoimmune related causes of catastrophic APLA, it increases further to 50%. So that is also true. Infections, trauma, surgery, malignancy, all are precipitators. This is also true. Raised APTT is a contraindication. No, this is a false statement. APTT is raised because of this antiphospholipid antibodies. So that's why it is falsely raised. Though it's a thrombotic tendency, because of these antibodies against phospholipid, we know that phospholipid is needed for the clotting mechanism, clotting to happen. When there are antibodies against these phospholipids, there won't be any clotting in vitro. So that's why APTT will be raised because of this antiphospholipid antibodies. Actually, it's not a contraindication. Rather, you need to give them heparin or anticoagulation treatment. So this 50% of the known this catastrophic APLA, they have underlying lupus or some connective tissue disorders, or maybe they are diagnosed case of antiphospholipid antibody syndrome. Maybe they have a bad obstetric history or tendencies at some unusual locations. Maybe young, less than 40-year-old with cerebral venous sinus thrombosis or mesenteric vein thrombosis or pulmonary embolism. So most of the times when young patients at with unusual site of thrombosis, either in the vein or the artery, you have to suspect APLA. And in first presentations, only some 50% of the cases they may present as a catastrophic APLA. Why catastrophic? Because it involves three or more organs or the tissues. Uh, so that thrombotic tendencies will be there in three organs so it presents as a multi-organ dysfunction. So that's why the septic shock is one of the differentials. So whenever such patients presents with kidney involvement, lung involvement, heart or brain involvement, multi-organ dysfunction. So in such cases, you have to sepsis comes as a differential diagnosis. It has a high mortality rate. It's common in females. Generally, they present with bad obstetric history or recurrent DVT or pulmonary embolism, especially in young people, those with a family history of first degree relatives with pulmonary embolism, mesenteric thrombosis, or CVST. They involve both the large and small vessels. Multi-organ involvement is the presentation. For rest, and there are various triggers for this catastrophic APLA. Most common being infections. That's why it close differential is sepsis. Sepsis with MODS. Pregnancy can precipitate it. OC pills initiation can precipitate catastrophic APLA. Sepsis, trauma, surgery, anticoagulation discontinuation, lupus or autoimmune disease flares, malignancies, especially hematological malignancies or adenocarcinomas like colon carcinoma, lung carcinoma. Uh, Lab wise, 60% of the times they have thrombocytopenia. So though they have low platelets, they have a thrombotic tendencies. In last lecture we have seen there are
Ma'am, I think we are facing some slides issue.
uh, right now I'm just at one slide only. So can you see this slide?
Ma'am, we can see question number 9.
Oh, can you see? I'm changing slides. Can you see the different slides?
No, ma'am.
Okay.
Now it's visible.
Yeah, but then in slide share, it's not visible. Why it's like that? I don't know. Now is it like? Can you read like this? Because in slideshow, I don't know. Then slides are not moving. So I'll just try once. Can you see the slides? Complete slides. I'm changing the slides.
Yes, ma'am.
Yeah. So ninth already we have covered. Now I was talking about question number 10. Now can you see this question?
Yes, it is
Question.
seen.
Yeah. So here we are talking about catastrophic APLA, and all of the following statements are true except. So the raised APTT is a contraindication for using heparin is a false statement here, because in APLA it's antiphospholipid antibody syndrome. Here the for clotting to happen, phospholipids are needed, and because there are antibodies against it, in vitro when you do testing, there won't be any clotting because of these antibodies. So it's like it acts like an inhibitor, acquired thrombophilia. So that's why there won't be any clotting. But it doesn't mean heparin shouldn't be given. Rather, heparin is the treatment. You need to give them anticoagulation because they have a thrombotic tendencies. So that is a false statement. Can you see the next slide? Can you see this?
No, we can't see the slides except for the question 10. We don't see the other slides.
So can you read like this? Because in slide share, I don't know, those slides are not moving. So without slide share, can you read the slide?
Yeah, we can
Else
read.
can, yeah. So this catastrophic apla, it's most common in females. Many a times they already have the history of antiphospholipid antibody syndrome. Maybe they had a stroke in young, or maybe they have cerebral venous sinuses thrombosis in young patients less than 40 years, and they have pulmonary embolism, maybe recurrent pulmonary embolism history is there, bad obstetric history is there, maybe beyond 10 weeks of gestation they have recurrent miscarriages. So all these are the clinical presentations. And uh, catastrophic apla is condition where it's a multi organ dysfunction, because here the thrombosis in as major small as well as large vessels occur. So small vessels of all the organs might be involved, like maybe brain, kidney, heart, skin, then lungs. So that's why it's a multi-organ disease. Catastrophic applies a multi-organ involvement, and they resemble sepsis with septic shock with mods, or sepsis with mods. So and even infection is one of the triggers. So it mimics like you can put sepsis with mods as a differential to catastrophic apla. But again, you have to be like, history will be significant. Maybe they have connective tissue disorders, or maybe the bad obstetric history with that, whatever I've already explained. Um, and the most common triggering event or causes infections. Second most is pregnancy, OC pills initiation, sepsis, trauma, surgery, anticoagulation discontinuation, and autoimmune disease flare, lupus flare, malignancy, especially hematological malignancy, adenocarcinomas of colon, lung. In such cases, most common lab abnormality is 60% of the times they have low platelets. So they'll have thrombocytopenia. And they will have this, again, the low platelets won't be severely low. Like in TTP HUS, you'll have a severe low platelets. In sepsis also, most of the times platelets are low, in DIC and all. But here the platelet won't be below 30 or below 40,000. There will be low platelets, but the severity won't be that severe as compared to other disease processes. And they present like a MAHA, so microangiopathic hemolytic anemia, because again they block the small vessels, then there will be schistocytes formation, raised LDH, low haptoglobulin. So same picture like a MAHA. So it's again differential to TTP and HUS. But again, in TTP HUS, we know that PT APTT will be normal, and here the APTT will be falsely high because of this antiphospholipid antibodies, like acquired thrombophilia, it behaves. So again, in lab wise, you can make out it might be APLA when your isolated APTT is prolonged. In sepsis DIC related, most of the times they'll have low fibrinogen, PT APTT both are prolonged, D dimer is high. So you can differentiate depending upon your lab tests. So again, schistocytes in TTP HUS will be significantly elevated. Here the schistocytes will be elevated, but they are scanty, not beyond 1%. Again, you can send anticardiolipin antibody, lupus anticoagulant antibodies, beta 2 glycoprotein antibody. But again, the problem is if the patient is already on heparin or warfarin, so your this lupus anticoagulant and all test won't be reliable, because when the patient is on warfarin, heparin, or maybe on NOACs also, in such cases test comes as a false positive. So test might come as a positive, but actually patient might not have APLA. So when patient is already on these anticoagulants, then you won't be getting benefited by sending lupus anticoagulant. And even if you are suspecting thrombophilia, in acute case, again, because of the clot formation, consumption of protein C, S, so all those won't be that reliable to send. uh, Again, you will get false positive syphilis tests. So that is also one of the different, when isolated APTT is prolonged, you can send your syphilis test and see whether it is falsely positive. That also indirectly indicates it is the antiphospholipid antibody syndrome. 25% of the cases may present as a DIC. So not only APTT, but your PT might be increased, fibrinogen will be low, D-dimer will be high. So these are the differentials you need to keep in mind. Thrombocytopenia with thrombotic tendencies, TTP, HUS, DIC, catastrophic APLA, sepsis, then even the malignant hypertension that can present as MAHA. So there are like 5 say HELP syndrome. So HIT. So these are all things where there is thrombocytopenia but thrombotic tendency. And some cases may present as a cytokine storm, especially when the sepsis related catastrophic APLA. So they can present with the high ferritin levels. Again, this clinic for diagnosing antiphospholipid antibody, you need one clinical criteria and one lab criteria. So in clinical, I'm not talking about catastrophic APLA, just antiphospholipid antibody syndrome. To classify it as antiphospholipid syndrome, there should be some vascular thrombosis at one or more clinical episodes of arterial venous thrombosis, and it is confirmed with imaging or Doppler studies. And there will be bad obstetric history beyond 10 weeks of gestation, multiple miscarriages and all. Then laboratory criteria, again, amongst all antibodies, the most clinically reliable significant is the lupus anticoagulant, because it correlates with the clinical severity. Lupus anticoagulant, but again, caveats being, if the patient is already on anticoagulation, it will be false positive. Then your anticardiolipin antibody and anti-beta 2 glycoprotein antibody, IgG, is more clinically relevant than IgM, and again, in moderate to high titers, it is reliable. So these are some things that you need to know about lab criteria. So again, mechanism here, because of the acute trigger like infection, surgery, trauma, pregnancy, malignancy, there will be complement activation. And because there are antibodies against this phospholipid, so again, these attachment of antibodies to the cell, they trigger the complement system. And that causes the microvascular endothelial damage and thrombosis. That thrombosis itself again lead to it blocks the small vessels of the organ, causing organ dysfunction, even the skin necrosis if the dermal vessels are involved. And damaged cell surface again in turn activate complement system. So it becomes a vicious cycle. Again, these patients, they present with hypertensive response also many a times. So it's because of the renovascular occlusion, because kidneys are the commonest organs which are getting affected in catastrophic APLA. So they present with the renovascular occlusion, and because of that hypertensive response, and you need to correct this hypertension, otherwise there will be intravascular hemolysis. Again, they may present as ARDS. Pneumonia will be the initial trigger. Or they may present as a diffuse alveolar hemorrhage, as pulmonary embolism. So CNS, if vessels are blocked, they may present as a stroke, cerebrovenous sinus thrombosis, seizures, encephalopathy. In heart, it may precipitate MI or stress cardiomyopathy, microvascular occlusions related coronary events. When adrenal vessels are blocked, may cause adrenal insufficiency and distributive shock. It may cause skin necrosis, digital gangrene, purpura, bowel infarctions, mesenteric ischemia. One of the etiologies in young patient might be this antiphospholipid antibody syndrome, or hepatic vein thrombosis, Budd-Chiari syndrome. So you need to know it can present as a multi-organ. It may involve different large as well as small vessels of multiple organs. So, and how to test now? This is very important, because in exam for your tables, CBS, they might give you some lab scenarios and some lab slide, and you have to identify whether it is, especially when they'll give you some scenario with some infection or maybe connective tissue disorders with raised APTT. And when there is a raised APTT and you mix, you do the mixing study. And with mixing studies means patient's affected serum is mixed with the normal sera. Normal sera will have normal clotting factors, and so when it's only the factor deficiency, if it is getting, it should get corrected by mixing study. If it is getting corrected, it means it is not lupus. If it is not getting corrected, the APTT is still delayed. And they do Russell Viper Venom test also. Again, that shows delayed coagulation, means APTT is raised, DRVVT is also raised. Again, it indicates it's a lupus. But if your APTT as well as DRVVT is negative, then also it rules out lupus. If either of these two is present, then you have to go for a next step, that is a mixing study. With mixing study, if your APTT gets corrected, it means there was clotting factor deficiency, and by adding normal sera, you are giving normal clotting factors, and that's why APTT gets corrected. Again, it rules out lupus, because lupus is the inhibitory antibodies. So again, if with mixing study it is not getting corrected, then you have to come to the final step of confirmation. You have to mix that patient's serum with the exogenous phospholipid, and now the APTT gets corrected. It confirms that patient has an antiphospholipid antibody syndrome. This is very important because in lab, this biochemistry, they might put this as one of the slides. So if the patient will have a falsely raised APTT and DRVVT will be raised, if both are normal, lupus will be ruled out. Then mixing study, with mixing study APTT is getting corrected, it means again it is not lupus, because it is clotting factor deficiency and not the inhibitor to the clotting factor. And final confirmation by mixing phospholipid, if APTT is corrected, because we know that there were antibodies against phospholipid. So now you are providing phospholipid, which helps in clotting. And if the APTT is corrected, it confirms your lupus status. Again, to diagnose CAPS, we need to have certain diagnostic criteria. There are 4 diagnostic criteria. Evidence of involvement of 3 or more organs, systems, or the tissue. It should be 3 or more. Okay. Then manifestations of development, it develops simultaneously or within a week of each other. So all these organs are involved either simultaneously or within a week. Histopathological confirmation of the small vessel occlusion, at least one organ or the tissue, histopath is showing thrombotic occlusion. And laboratory lab confirmation with antiphospholipid, lupus anticoagulant, and whatever antibodies we have discussed. So these are the 4 criteria. When all the 4 criteria are present, then it is a definitive CAPS. When criteria 1 and 4 should be there, and sometimes 2 is there or sometimes 3 is there, not all 4, but either 2 is missing or 3 is missing, then you can label it as probable CAPS. Or when all the 4 are present, but the first criteria of 3 organs is not fulfilled, maybe 2 or lesser organs are involved, then also you have to label it as a probable CAPS. Then the same thing, I have already explained this. And again, the most reliable is the lupus anticoagulant antibody. It correlates with the clinical severity of the thrombosis, and followed by beta 2 glycoprotein and anticardiolipin antibodies. But again, you need higher titers, that to label as a significantly positive test. Again, I already discussed mimics, microangiopathic hemolytic anemia like TTP, HUS, HIT, DIC, particularly purpura fulminans, because in DIC, early DIC, it's a thrombotic DIC. It's not bleeding variety where already consumption coagulopathy has not happened yet. So medicine-related thrombotic microangiopathies like ticlopidine, clopidogrel, malignant hypertension, disseminated malignancies, they can mimic catastrophic APLA. Others being sepsis, adrenal insufficiency, vasculitis, endocarditis, cholesterol emboli. So these are all the differentials. Now the treatment part. Whenever you are suspecting CAPS, you have to see whether there are any precipitating factors. If it is an infection, you have to treat it. If connective tissue disorders, then maybe pulse steroid you need to start, and start immunosuppressants, maybe rituximab if it's relapsing lupus, rheumatoid arthritis related, then cyclophosphamide, eculizumab might be needed. So these are all the treatments, and IVIG also if it is especially immune thrombocytopenia and all, immune related cause. So these are all the treatment modalities. Again, same, identify and treat the underlying cause, aggressive antihypertensive treatment, avoid IV catheters, especially the arterial lines, because there is a chances that small large vessel thrombosis occurs in it may cause thrombosis of those vessels also, and again the clot may dislodge from these devices. Anticoagulation with heparin, long term with warfarin. Always remember, NOACs are not preferred, they are inferior to warfarin here. That's why start initially with heparin, and long term patient needs warfarin. Again, for heparin activity, you have to check anti-10A levels, because many a times they have, especially when there is a purpura fulminans, uh, uh, they have this factor C deficiency, and antithrombin 3 deficiency. Antithrombin 3 deficiency causes heparin resistance, and you need higher doses of heparin. And why you have to check anti-10A levels for heparin here? Because APTT will be anyways elevated, so it won't be giving you idea of whether your heparin dose is sufficient or not. And there are high chances of heparin resistance as well, so your dosage requirement might be high in these cases. So better to check anti-10A levels. Uh, so 5 consecutive plasma exchanges or IVIG is needed. Plex is preferred, especially when there is a microangiopathic hemolytic anemia related causes are there. Like we have seen in TTPHOS, Plex was preferred. And the renal dysfunction, then also Plex is preferred, while IVIG is preferred in immune thrombocytopenia cases. Pulse steroid with taper over 4 to 6 weeks, and refractory cases, immunosuppressants like rituximab, cyclophosphamide, eculizumab, especially eculizumab in thrombotic microangiopathies. So the next question, we have already discussed about this mixing study and all. So 32-year female with a bad obstetric history, P4L1A3, got admitted with history of headache since 2 days, had one episode of GTCS, altered sensorium, positive of left leg movement. CT brain was done, suggestive of right frontal bleed, unusual location, but it means it was not like in particular ACA territory or something. So CT venography was done, which suggested CVST, cerebral venous sinus thrombosis, for which she was started on injection Clexane 0.4 ml subcut BD. Her labs showed following results. CBC here is showing thrombocytopenia. INR is okay. APTT is elevated. See here again, clue is young female with unusual site thrombosis, presented with now CNS involvement. Right now there is a one single organ, but bad obstetric history is also one of the clues, and APTT is raised. So DR-VVT screen ratio is 1.8. Again, this means DR-VVT time is prolonged. We know that APTT is prolonged, DR-VVT is prolonged. It indicates there is some antiphospholipid antibody present. So mixing study was done with normal pool plasma, and DR-VVT still remained prolonged. Normally, if there is a clotting factor deficiency, it should get corrected, but it is still prolonged, means there are inhibitors to the clotting factors that are present, that is antiphospholipid antibody. So it interprets the answer here is the presence of APLA antibodies, not the clotting factor deficiency. So, 50-year-old, this is the last case. 50-year-old diabetic hypertensive IHD, chronic liver disease patient presented to ER with a history of hematemesis. Vitals were okay except sinus tachycardia. On ABG, he had high non metabolic acidosis with hyperlactatemia of 8, HB7, and blood grouping cross matching was sent. Blood products reservation form is sent. IR is 2.6 and rest of the coagulogram is awaited. All meanwhile, ROTEM was done. And can anybody interpret this ROTEM? And what will you do next? Whether the full values are seen or not, I don't know. Can you see the full slide? Can you see full slide? Can
No.
Now? Now I'm moving the slides. Are they moving?
No, they're not moving.
Okay. So can you see extem and intem?
Yeah.
Can you say extem?
Yes.
So from CT, CFT, 8 and MCF, can you just make up what is the abnormality in this? See the first because this is very important. Both in CBS and CCS, they might, like in trauma cases or maybe in liver cases, obstetric hemorrhage, they can put this ROTEM in both CCS and CBS. So you need to know about ROTEM. So can you see extem, intem, fiptem, aptem, all four? Can anybody interpret? So see, in ROTEM, first and foremost is you have to look at extem and fiptem. So, and for that, you should know at least four values. Even from the shape you can make out, but you should know four values. CT means this clotting time. It is same as R of TEG. CFT is clot formation. So CT is clot initiation. CFT is the clot propagation. So for clot initiation, you need clotting factors. Your normal clotting factors you will get through FFPs and all. And CFT is the clot propagation. For propagation of the clot, you need platelets and fibrinogen. And A10 and MCF is the maximum clot strength or the clot stability. That depends on your platelet, fibrinogen, and fibrinolysis that is happening. So you just theory wise, you should know that CT means clot initiation. Clotting factors play a role in it. CFT is the clot formation time, which is propagation, for which you need platelets and fibrinogen. And MCF and A10, the maximum clot formation, is the clot strength or the clot stability. So it depends on your platelet, fibrinogen, and the fibrinolytic system. So alpha angle here again, it's more of a contribution from fibrinogen, more of a fibrinogen contribution, and some from the platelet. So first and foremost, you have to know certain numbers, like in FIPTEM. So first you have to look at the FIPTEM. So this TEG is FFP based modality, and your ROTEM is more of a cryo fibrinogen and a platelet based modality. That's why fibrinogen ke liye first you have to look at the FIPTEM. And in FIPTEM, the most important things that you need to look at the A10 and MCF. A10 is the amplitude after the clot after CT. Like CT is the first 2 mm clot formation initiation. From 2 to 20 will be your CFT, propagation. And A10 is after the clot starts propagating, the whatever the amplitude first, after first 10 minutes, whatever the amplitude is achieved, it is A10. And MCF is the maximum clot formation. It is the maximum amplitude that is achieved. It is MCF is like a MA of TEG, maximum amplitude. And A10 is a part of it. You cannot wait for maximum amplitude to happen and all. So you, to quickly interpret, A10 is important. So in FIPTEM, A10 beyond 9 mm is normal. Roughly remember like this. Again, for cardiac patient and liver patient is a little different. For liver patient, you don't aggressively correct all the clotting factors, because we know that it's a balanced hemostasis. But CABG patient, cardiac patient, you need to give little higher dose as compared to liver patient. So in FIPTEM, A10, here it is A10 is 15 mm. So our criteria is beyond 9 mm, it is fulfilled. So A10 for FIPTEM is normal. So fibrinogen contribution to the A10 is normal. Even in MCF. So in FIPTEM, MCF of up to 23 is okay. MCF of 15 to 23, up to 23 is normal. So here both the A10 and MCF are normal. So here the height, maximum amplitude height contribution from the fibrinogen is normal. So we know that another factor is now what is left that participates in the maximum clot formation is, there are two more factors, platelets and fibrinolytic system. Fibrinolytic system is very easy to identify. There is no in TEG also you have this typical hyperfibrinolysis curve where it narrows down. In graph also you are not seeing any narrowing anywhere. So it doesn't look fibrinolysis, and this is maximum lysis in percentage. That is also, it is not showing any abnormal value. They have not given any value. So it is not fibrinolysis. Then what is left is the platelet. In XTEM and INTEM, the A10 and MCF, they are low. Because in XTEM, INTEM, here the normal value of the MCF will be 50 to 70. And A10 normal value will start beyond 25 is normal. So you can label it as a A10 MCF in INTEM and XTEM are abnormal. And A10 and MCF in FIFTEM is normal. This means clot propagation MCF is your clot stability or maximum strength. And that is dependent on three factors: fibrinogen, platelets, and fibrinolytic system. So again, the typical tapering down shape is not there. And even in APTEM, if it is a fibrinolysis, APTEM is there is a aprotinin is added. Aprotinin is like tranexamic acid. If it is fibrinolysis with tranexamic acid or like with aprotinin, it should get corrected. But you have to compare it with the XTEM. Always remember, HEPTEM you have to compare with INTEM. HEPTEM means heparin effect, because we know it is the intrinsic pathway. So you have to compare HEPTEM with INTEM, and APTEM, which is like a tranexamic acid, with XTEM. So here you can see XTEM and APTEM values are more or less almost same. If it is fibrinolysis, in APTEM means after adding aprotinin, which is like a tranexamic acid, it should get corrected. But this A10 MCF is not corrected. It is same. It means it's not, again, this is second thing that rules out there is no increased fibrinolysis. There is fibrinogen is normal, fibrinolysis is not happening. Then what is left is platelets. So either there is a platelet deficiency or there is a platelet dysfunction. If patient is on antiplatelets, then we can call it as a platelet dysfunction. Can you are you understanding this? Because this is very important. If you know the basic concept, then it becomes easier to identify. So this is the normal graph. It looks like this. You can see this, the CT, it's the clotting time for INTEM will be, naturally it is normally it is higher than the EXTEM. So you just need to remember 4 values. CT of EXTEM is generally between 40 to 80 seconds. CT of INTEM is generally between 100 to 240 seconds. A10 of INTEM EXTEM is generally beyond 25 mm. And MCF, maximum clot formation, that is also ranges between 50, 55 to 70 for both INTEM EXTEM. For FIPTEM, A10 beyond 10 mm is normal, or 9 mm is normal, and your MCF from 15 to 25 is normal. So for FIPTEM, A10 value and MCF values are much lower than the INTEM EXTEM. Only these 4 things you need to remember. And 2 more things is, you have to compare HEPTEM with INTEM, intrinsic pathway, heparin, APTT. So HEPTEM with INTEM, and APTEM, which is aprotinin, which is like tranexamic acid, with the EXTEM. If your HEPTEM is INTEM is abnormal and HEPTEM is normal, it indicates, because the heparin effect is nullified, because by heparin is enzyme, the graph becomes normal. It indicates heparin effect. That heparin effect might be drug, you are giving externally heparin, or it might be heparinoid effects. In CLD patients, many times they produce heparinoids, endogenous heparinoids, and that can produce this. And APTEM, again, it's a increased fibrinolysis. Mostly it is a primary fibrinolysis, maybe trauma, obstetric hemorrhages. So all of these cases, there you need to give tranexamic acid. So you need to know this. Again, this is the TEG. For TEG also, now they, in European countries, they use ROTEM. So you'll be having questions on ROTEM. The only important thing about TEG is that you need to know is, see this 4th graph. This is the fibrinolysis even before the primary clot formation. So there are 3 phases, no? Clot initiation, propagation, and then lysis. But here there is no complete clot formation. Before complete clot formation only, there is a fibrinolysis that is happening. You call it as a primary fibrinolysis. And the 6th graph, here there is a narrowing at the end. The whole clot is formed, and at the end there is a narrowing, that is a lysis, which is a early DIC. Early DIC where it is a thrombotic DIC, like a purpura fulminans, because there is a lot of fibrinogen, lot of thrombin formation, clot burden is high, and body is trying to get rid of this clot by causing fibrinolysis. So here, rather don't give tranexamic acid. It will worsen your thrombotic picture. Here patient presents with the organ dysfunction, purpura fulminans. So in such case of a early DIC, where there is a secondary fibrinolysis, you have to give anticoagulants. You have to give DVT prophylaxis for these patients. So this is very important. You need to know the difference between the 4th graph and the 6th graph. 4th graph is before the primary clot formation, the fibrinolysis is happening. It is the bleeding tendency. You have to give tranexamic acid, primary fibrinolysis, especially in trauma, obstetric hemorrhages, liver dysfunction. And the 6th graph, it is a sepsis, early sepsis, which is rather thrombotic, and this fibrinolysis is the secondary fibrinolysis. Rest of the graphs, I think most of us know about. Even the 4th graph indicates tissue plasminogen activator. If somebody is lysed with tenecteplase, altiplase, then also your primary fibrinolysis graph will look like a graph number 4. So that's why when you lies with this altiplase, retiplase, and if patient bleeds in the brain, you give them cryoprecipitate to correct fibrinogen. So again, same, you need to know the terminologies. The ROTEM and TEG, there are like, I have already explained, the R is like CT, K is CFT, alpha angle will be same. Contribution of fibrinogen will be more in this as compared to platelets. MCF, again, MCF is like MA, where both fibrinogen, platelets, and here fibrinolytic system also plays a role. A10, again, platelet, fibrinogen, and fibrinolytic system. But first and foremost, you have to start with A10 MCF of 15. If that is normal, then you have to look at the XTEM. If that is also normal, platelets are okay. And if still your CT is prolonged, and then you have to look for the clotting factor deficiency hai, or is it some heparin effect. So step by step you have to go. First you have to check FIBTEM, then XTEM, and if XTEM is also okay, then CT of XTEM, INTEM, and then again the graph itself will show fibrinolysis. If fibrinolysis is also ruled out and APTEM is also not abnormal, you see HEPTEM. If heparin effect is also not there and only CTs are prolonged, then it's clotting factor deficiency. So TEG is more of a INR based or FFP based, and ROTEM is more of a fibrinogen, cryo, and platelet based. And I have already explained this. In this table, INTEM, XTEM ka CT you need to know. CFT no need to remember as such, but you can just see some numbers. But CT of INTEM, XTEM, and MCF of INTEM, XTEM, and FIBTEM, that you need to know. You can see here the MCF of INTEM and XTEM is same, 50 to 70. A10 is 44 to 66. It's the values are more or less same as a MA or alpha angle in TEG. And in FIBTEM, these are much lower. MCF is 9 to 25, A10 is 7 to 23. So you need to remember these 4 values. And HEPTEM will be same as your INTEM. And APTEM will be same as your XTEM. A maximum lysis, again, if normally maximum lysis should be less than 15. If this value is beyond 15, it indicates fibrinolysis, extra hyperfibrinolysis. So again, the graph is showing same. Again, see, in ROTEM you can make out fibrinolysis even with the shape. In the last slide, you can see this spindle shape. It indicates hyperfibrinolysis. Even the CT is prolonged here. You can see in if this CT is prolonged, but with the HEPTEM, if it is getting corrected, it means it's a heparin effect. If in HEPTEM also it is remaining prolonged, it indicates clotting factor deficiency. Again, for platelets, your thrombocytopenia, platelet dysfunction, and especially here in FIBTEM, even the shape you can see here. There is no like, it looks like a flat line in FIBTEM. By visual, this thing also, you can get a clue that fibrinogen is very low. So dictum is first see FIBTEM, see whether fibrinogen is low, then see XTEM. If FIBTEM is normal, then see XTEM, see if platelets are low. If that is also not the case, and if the CT is prolonged, you have to see whether it is prolonged in both XTEM and INTEM. If INTEM CT is prolonged, you have to do HEPTEM and see whether that prolonged CT is because of heparin or heparinoid effect, or it is because of clotting factor deficiency. And you are seeing this spindle shaped, or if there is a APTEM which is getting corrected, XTEM is prolonged CT, but in APTEM it is getting corrected. Both CT, MF, A10, everything is getting corrected. It means there is a fibrinolysis and you have to give tranexamic acid. For heparinase, if it is getting corrected, you have to give protamine for the heparin reversal. So this is very important. It's all theoretical, that's why I'm not going into details, but A10 is important, MCF is important, that you need to know. And maximum clot lysis, more than 15% is abnormal, less than 15% is normal. Again, now certain case scenarios. Can anybody read this? What this rotem shows? First one is extem, second is intem, fiftem, and aptem. So again, go with the whatever the flow I have told. First, you have to look at the fiftem. So A10 of fiftem is 9 mm and MCF is 10 mm. Is it normal? Can anybody answer this? Whether it is normal, fiftem, A10, and MCF? Can you see the slide? Students, can you see the slide? Hello? Can anybody see the slide?
Yeah, we can see the slides.
Yeah,
Is
so
it-
can you tell me whether this fiftem, A10, and MCF is normal or not? I've told you, A10 beyond 9, 9 and 9 plus is normal. MCF also in fiftem, because these values are much lesser than extem and intem. You have to just remember certain values and you can see the fibrinogen graph. It looks normal. And in this max, there is no narrowing. So fibrinolysis shape bhi nahi hai. Even maximum lysis percentage, they have not given anything. So fiftem looks normal. Then you have to move to extem. And if you can remember the clotting time CT, it will be uh, better if you can remember. So even in extem CT, normally it is 40 to 80 seconds. So again, CT looks normal. But again, extem mein first you have to see the A10 and MCF. That is also normal. So your fiftem is normal, extem is normal, your CT is normal. So fibrinogen and platelets are absolutely normal. Now you have to look at the intem. So intem ka again A10 MCF is more or less same as extem, which is normal. And CT here is 200 second. But again, in intem, 200 second CT is because first initially is a tissue factor activation, no? So that's why contribution from the extrinsic pathway is earlier, and that's why CT is lesser here. 40 to 80 is normal in extem, while it is 100 to 240 in intem. So again, it is in the normal range. A10 MCF values are normal. And there is no fibrinolysis spindle shape or narrowing is seen. And again, in aptem, here the values of aptem and extems are more or less same. So there is no any correction. So this is a normal rotem, normal graph. So can anybody tell me what is this? Can you read? Can you read this? Again, go with the fiftem first. Here again, shape with shape also you can make out this fiftem. The thickness has reduced. A10 is 3 mm, MCF is 3 mm. Below 9, it is abnormal. So it is less. So contribution from fibrinogen is less in the clot stability. So there is a deficiency of fibrinogen. And in extem also, A10 and MCF is less. It should be beyond 45-50. So again, MCF is less in XTEM, that contribution we have already discussed. MCF में A10 and MCF में contribution 3 चीजों का है, fibrinogen, platelets, platelet में platelet number as well as platelet function, and fibrinolytic system. Here there is no narrowing. Maximum lysis they have not mentioned beyond 15%. So fibrinolysis is ruled out. Now in FIPTEM values are low. So in XTEM may A10 MCF is low because of the contribution from the fibrinogen. So first you have to correct fibrinogen. If after giving cryoprecipitate or fibrinogen concentrate, if your A10 and MCF in FIPTEM becomes normal, but your XTEM A10 and MCF remains low, it indicates now the platelets were also low, and now you have to correct the platelets. You are understanding this because this is very important. Can you read this? Even with the shape, you can make out what is happening. And already in the slide also they have mentioned. It looks like a spindle shape. So spindle shape.
Hyperfibrinolysis.
Yes. But again, you have to rather with shape also you can make out, but you look at the aptem. When there is a hyperfibrinolysis, you have to compare XTEM and aptem. In XTEM, your MCF and your A10, look at the values and look at the value of CT and value of LI, maximum lysis. Here the maximum lysis in XTEM is 94%, while in aptem maximum lysis is 0%. Normally it should be less than 15%. So the hyperfibrinolysis is getting corrected in aptem. That also gives a clue that it is hyperfibrinolysis. Shape as well as you can see, ideally if it is not the hyperfibrinolysis, your aptem and XTEM should look same. But here the XTEM is showing spindle shape, but your aptem is normal. It means because you have added aprotenin, which is like a tranexamic acid, your hyperfibrinolysis is getting corrected, and that's why there is a normal shape. So it indicates hyperfibrinolysis, and treatment is tranexamic acid. Sorry for this, slide is cut off, half cut off. But you can make out, see the, again, the process should be the same. Here they have not mentioned FIPTEM. Actually, ideally there should be FIPTEM. First, let's consider FIPTEM is normal. Now next is XTEM. In XTEM, A10 and MCF, they are slightly low. But in CT looks normal, which is within 40 to 80 seconds. So my next step is INTEM. In INTEM, there is no graph only. There is no clotting that is happening. And when you look at the CT clotting time, which is normally in INTEM, it should be 100 to 240 seconds. It is 2868. So it is grossly increased. And when you look at the HepTem and INTEM should look same. Now with HepTem means there is a heparinase enzyme, and because of that the heparin effect has gone and the graph becomes normal. So it indicates heparin effect, the clotting factor deficiency because of the heparin effect. And here you can see in HepTem, CT also becomes normal, 174 seconds. So it indicates heparin effect. Maybe patient on CPB, cardiopulmonary bypass, then you have to decide about the protamine reversal. And many times in liver transplant patients and cirrhotic patients, it is the endogenous heparin effect, heparinoids. Either therapeutic heparin or endogenous heparinoids. So this was the last slide. In ROTEM, you will just have 4-5 combinations: fibrinogen deficiency, platelet deficiency, heparin effect, hyperfibrinolysis, or the clotting factor deficiency. And always go from FIBTEM to EXTEM, then INTEM. Compare INTEM with HEPTEM and EXTEM with APTEM. There are only 4-5 combinations. And just remember four values: CT of EXTEM and INTEM, A10 of EXTEM and INTEM will be same, A10 of FIBTEM will be different. So only these four, total 6 values you need to remember. So we'll end class here. You can read about ROTEM in deranged physiology, as well as there are on YouTube there are some few good lectures as well regarding ROTEM.
Thank you, ma'am.